Chapter 12. This is a good one. And well, they're all good, but this is one that is very popular in healthcare law and policy and ethics and all the good stuff. So let me get my page how I want it. Okay, so I'm going to read from the book and follow this PowerPoint. Maybe, hang on. Okay, there we go. Learning objectives are listed here and on page 233 in the book. Consent is in the healthcare setting is a voluntary agreement by a person who possesses sufficient mental capacity to make an intelligent choice to allow a medical procedure or treatment proposed by another to be performed on himself or herself. Some key words in there: voluntary, mental capacity, intelligent choice, which intelligent choice I'm referring to information provided, and they need to know what type of medical procedure it's going to be. We'll get into that a little bit more. So, informed consent is a legal doctrine where the patient has the right to know the potential risks and what is actually happening. So, for example, I'll go back up on page 234 a little bit. Touching another human being without authorization to do so could be considered battery. In a hospital, it's usually implied that, or a healthcare facility in general, if you come in for treatment of some sorts, that it is okay for us to touch you in a normal, routine way. But we just have to be really careful because out in public with a random stranger, if you were to put a blood pressure cuff on them or try to start an IV, that would be battery. That is, there is no consent there, implied or conformed or anything, or informed, I should say. So yeah, just be careful with that. Okay, forms of consent. We've talked about this before. Verbal, written, implied. Again, verbal consent within a hospital does not do well, and within any type of healthcare setting. I need to quit saying hospital. I need to say healthcare setting. We really want everything written. That is the best form of consent. Implied does cover us, like I said. When you enter into a healthcare facility, you're generally asking for care. So in the law, the eyes of the law, that we do have some implied consent there. Statutory consent, judicial consent, that's in the book on page, hang on, 236. Then we get into physician's informed consent. So ultimately, it is the physician's responsibility, physician being doctor, surgeon, radiologist, that level, to disclose everything to a patient, to get that informed consent, to give that information needed. It is not a nurse's responsibility, it's not a technician's responsibility. It ultimately lies within the doctor, the physician, or I should say, physician assistant, nurse practitioner. They're all on the same level as a provider. Nurses, most cases, have no duty to give consent and or to get consent from a patient. We advise and we can confirm that a physician has explained the procedure, and we can witness a signature on the consent form, but it is not a nurse's duty to do that. And it's also not a dental hygienist duty in that arena, or a radiology tech duty in that arena. It is, again, let's go back up here. It is the physician. They have to disclose the risk, the benefits, the alternative treatments, etc. Hospitals informed consent. I'm trying to make sure I follow along in the book. I'm kind of flying through the book. So the doctor and the nurse's difference in consent is on page 236 and 237. Hospital informed consent. Okay, I'm on the bottom of page 238. Not generally responsible for informing patients of risk, benefits, and alternatives. That's correct. Some cases, a hospital may have a duty to inform or explain in regards to imaging, some laboratory items also. Um, but again, it's sort of implied that when you come in, that you're agreeing to treatment. Patients informed consent. The court, so yes, a patient's ability to understand the risk, benefits, alternatives, evaluate and receive the information provided by the physician, express, the patient being able to express his or her treatment preferences. This is involuntary. This is all part of having that perfect consent. And we want it to be perfect in the eyes of the law. So it would really it's not going to be too well. It could be hard. It could be very challenging for a plaintiff to say, "I was not informed." There's a lot that goes into that. Um, imagine a trauma victim coming in and a spouse having to give consent for A, B, or C, but that spouse is in shock because of what's just happened to their loved one. And even though everything was read to the person or spoken to the person, if that person did not receive it and has not processed that information, they're not in a cognitive ability to give consent. And sometimes things go wrong and they do stuff anyway. So a good example on page 239 of the section that says, "Why did you let them do that to me?" So be sure and read that. Hang on, let's get through. Here we go. Information to be disclosed, the bottom of page 239. Needs of each patient can depend on so many things: age, maturity, and mental status. Um, just like my trauma victim uh, example, let's change it to someone who's under the influence of a substance. Their mental status, you really have to know the person's mental status and their ability to receive the information and process what's being told to them. And that continues reading that page or that information on page 240. Subjective tests, that's listed on 240. Also, objective tests, yes, that's all of that's on page 240. Please let me know if you have any questions about it when you read it. And then it continues on 241. So 242, this is really what comes into play in courtroom or health law is the assessing the decision making capacity. That is something that is on the nurse, doctor, that's on everybody, even though it's ultimately on the doctor, yes, or physician. But we may have to step in and advocate if we do not feel like a person's in the has the ability to make a decision for themselves. Adequacy of consent, that is listed there. Verbal is as binding as written, but is difficult to corroborate, so it's always better to get stuff in writing. Written consent describes the nature of the patient's illness, procedures that's consented, risk and responsibility, or risk and probable consequences, probability. Okay. Written consent also describes patient's physician witnesses indication that the patient understood the nature of the proposed procedure. All of this is on a form, by the way, that is provided by the hospital itself. Special forms consent. These start on page 242, and it goes all the way over to, I'm going to lose it. I'm going to lose my place is what I'm referring to. Let me flip this slide. Where does it go next? Statutory consent. All right, so read over 242, 243. Competent patients versus incompetent patients. Guardianship comes into play. Parental consent, the emancipated minor in our state. Hang on. I feel like I'm lost in the book. Give me just a second. Whom consent? I was lost. All right, so I just flew through statutory and judicial consent, and I didn't catch up with the slides. Okay, so now I'm caught back up. Who may consent? Competent patients, guardianship, parental consent, and emancipated minor. In our state of North Carolina, an emancipated minor can be somebody who's given birth, someone who has legally divorced their parents, or if they are married, no matter what the age. It could be a 12-year-old, 14-year-old, 16-year-old. And of course, by 18 in our state, you are truly an adult. Incompetent patients, this is going backwards compared to the book. Sorry, hang on. Incompetent patients is listed on page 243. Limited power of attorney. This is something I will always say when I come across documents like this, advanced directives. Limited power of attorney, or even like a health care power of attorney. This is something anybody and everybody over the age of 18 should have. Just this to me is just as important as having a driver's license, social security card, CPR card. I think everybody should know CPR, and everybody should have advanced directives if you are over the age of 18. Local banks do it, healthcare facilities do this. You can get it done for free. You can even go Google a document and copy it. anyway, I'll get off that little soapbox, but it's very important because it gives somebody the authority to make medical decisions for you if you're not in a capacity to do so, whether it was a trauma, whether it was there's so many reasons why you wouldn't be able to make decisions for yourself, but just keep that in mind to appoint somebody. Okay, refusal of treatment. That was on page, oh no, we're moving forward now. That's on page 246 in the book. And these are real scenarios. Religious beliefs come into play, especially with uh, sometimes blood. We can't give blood products to certain religious groups, and we have to respect that, whether we agree with it or not. We respect that, and we always do what the patient asks. There's also certain, what am I trying to say? Bear with me. There are certain, not socioeconomic, that's not the word I'm looking for, cultures. That's the word I'm looking for. Certain cultures that uh, certain genders will make decisions for the spouse, or you're not even allowed to speak if you're a certain gender. The other gender will speak for you in healthcare facilities, and you have to be respectful of their wishes and be culturally aware of the differences like that when it comes to refusal and agreeing to treatments and signing consents. So yeah. Okay, discharge against medical advice. That's on the bottom of page 247. Many insurance companies will not pay for your healthcare facility visit if you discharge yourself against medical advice. So keep that in mind. And usually, when we tell patients that, they simmer down a little bit, and the refusal or the demanding to leave, that goes away when we start talking about money. That if you have the right to leave, but please know that your insurance company may not pay for this hospital stay. Okay, and then is this my last slide? Nope. Okay. When in doubt, on page 249, the book does a great job. We always err on the side of life. If we don't know somebody's wishes, if we don't know somebody's religious or cultural, stature, or how they live their life, what they prefer, especially if they don't have advanced directives on file or what have you, we always err on the side of life. We will save your life if we don't know that. Most of the time, if somebody has special request that is on file, something like a DNR. If it's a terminal cancer patient, there's no reason to continuously do CPR on somebody who is terminally ill. And if they do not want to be resuscitated, we should not actually do CPR. So that's just one example. But if, again, somebody who comes in, and even though you may be a terminally ill patient, you may not have signed a DNR, and that's totally okay too. We will definitely do CPR on you and keep you alive for as long as you want to be kept alive. Defenses for failure to provide consent. This last page in the chapter goes over this. Again, it's very challenging to corroborate or to prove that someone did not receive consent. It would just have to be blatant for a jury or a judge to award, but it does happen, and the book does have a few of those examples. So anyway, please ask me any questions if you have them. And oh, there's one more slide. Ethics, informed consent. Yes, it becomes a big deal with ethics. The autonomy is a big thing, and giving the oral disclosures of the risks, the benefits, the alternatives is always a big thing. We want our patients to be informed and give consent to the best of their ability. Again, please let me know if you have any questions.